Hello friends, greetings from Aurangabad Academy of Pediatrics. Myself Dr. Khadke, I am going to talk about immunology which is related to the vaccines. Now the topic which was given to me was immunology during our day-to-day practice of vaccinology. As all of us know that the vaccine preventable diseases are still a major cause of mortality and morbidity in our India. In spite of the fact last 30 years we have started universal immunization program, IIP, WHO and lots of NGOs are working for immunization and spreading the knowledge as well as implementing this immunization in India. Unfortunately, still we are lacking in a total coverage and not more than 60 to 65% nationally we are able to cover these vaccine preventable diseases as far as the coverage goes. And if you see the percentage of increase in coverage, it is almost only 1% per year. So we are still far away from really driving these vaccine preventable diseases out of India. What I am supposed to talk today is about the immunology which is related to the vaccine part of it. As all of us know that these are the major causes of under 5 deaths and which has not changed in last 20 years. Pneumonia, diarrhea, malnutrition, preterm births and other infections. What is most important is, even if we have a good coverage of measles vaccine across India, around 40% of these diseases can be prevented just by giving a good measles coverage nationally. And that is the reason why government has come up with MR campaign and they want to give this measles and rubella to almost 95% of the children who are going from 9 months to 15 years. So if you really cover these measles and rubella, 95% of these children who are susceptible, probably we will be breaking the transmission and we will be controlling these measles and rubella in future generation. So what is most important is not only vaccinating children, but what is most important is having a good coverage across pan-India to control these vaccine preventable diseases. So mortality and morbidity through these vaccine preventable diseases can be reduced by 40% if you just give measles vaccine, and rest of the vaccines if you give another 10 to 15% of these under 5 days can be prevented. Now coming to the immunity. What is immunity? The immunity is basically the capacity of the body to resist the microorganism for entering into the body and causing a disease. It is as simple as it is. The microorganism should not enter in the body and should not cause the disease. That is what is called as immunity. And we have a complex immune system in our body which has physical barriers, chemical barriers, and we have specific cells like T cells and B cells which really prevent us from getting the infections day in and out. Now there are specific barriers as well as non-specific barriers. Now these non-specific barriers means you have mechanical barriers like skin. Now skin is a multi-layer organ which is preventing you from the outside infections and which has multiple layers, and keratin which is preventing these bacteria and viruses to come into contact with the human body and cause an illness. Similarly, there are few areas like mucoid areas, mucous membranes like oral mucous membrane, genital mucous membrane. These are moist areas which has some chemicals, which also prevent this entry of these microorganisms in the body and cause a disease. Then you have mechanical barriers like cilia. They are in respiratory passages, which also prevent these microorganisms to go inside the body. So these physical non-specific barriers, they make a lot of protection as far as this immunity goes. Similarly, we have different pHs in different body systems. Like we have acidic pH in stomach, we have alkaline pH in GI tract, we have acidic pH in genitourinary system, where these all pHs prevent this proliferation of these microorganisms and coming into the contact with the body and cause a disease. So apart from this, before really going to the complexity of this immunology, we should know the terminologies which are used in our vaccination. Immunization and vaccination, these two terminologies are used as they are same, but it is not so. The vaccination means giving of that antigen to the body, but immunization means basically having an immune status after giving this antigen to the body. So the process of inoculation is called as vaccination, while getting an immune status or protection is called as immunization. And what is endemic? The endemic is basically the disease occurrence of a fixed number throughout the year in a specific geographical population is called as endemic. So if you take 12 months of year, then the disease percentage would be same in almost all months, and that is called as endemic. What is epidemic? So if you have a number of cases which are increased than what is expected from this endemic area, we call it as an epidemic. And when it crosses this geographical barrier, national barrier, we call it as a pandemic. Then what is vaccine efficacy? Suppose we give vaccine to almost 100 children, and out of these 100 children, if 80 are protected from the disease, then we call it that the vaccine is 80% effective. So coverage minus effectiveness is efficacy is decided on the vaccine potency of itself. Then what is reproductive rate? Now this reproductive rate means something. It calculates the transmissibility of the disease. So if the reproductive rate is more than 1, that means the disease is active in community, and if the reproductive rate is less than 1, then the transmissibility is less. So this is very important from the PSM point of view. When you talk about epidemic, what was the reproductive rate before the measures, and what is the reproductive rate after the measures? Then what are the contraindications for giving vaccine? Now contraindication for giving vaccine means absolute no to the vaccine. And there are very few contraindications which are there. Most of them are basically the precautions rather than the contraindications. So anaphylaxis is a major contraindication for almost all vaccines, and there are few vaccines which cannot be given, live vaccines cannot be given when you are steroid dependent or when you are immunocompromised. Otherwise, most of them are precautions rather than the contraindications. Then what is seroconversion? Now when we talk about that the vaccine has been already given to the patient or child, the child has a detectable antibodies in his serum. So these detectable antibodies in the serum is called as seroconversion. But are they protective? So you require some GMT titers, that is mean geographic titers, to achieve a protection against that disease. And when you have that GMT titers in the body, then you call it as a seroprotection. You may get a seroconverted child, but if you want a seroprotection, then basically there has to be a significant GMT titers in the blood so as to prevent this illness to happen. Coverage, as I said, that basically we should have a better coverage, as we already know that nationally we are only 60 to 65% coverage is only there for all these vaccine preventable diseases. Now coming to the types of immunity. Now the immune response is basically of two types. One is called as innate immunity. Now what is innate immunity? Innate immunity is something which you are born with. This innate immunity is something which you are born with, and it is a species specific immunity. So the animals would have different immunity, the human would have different immunity. So you are protected from many illnesses which are common in animals, but they are not found in human beings. That is what is called as innate immunity, or a specific species oriented immunity which you are born with. Then something which is called as adaptive immunity. Adaptive immunity is something which you acquire after you are born. So once you are born, you acquire some immunity against some diseases, and that is called as adaptive immunity. Now this adaptive immunity can be natural. So it can be passively from mother, or it can be because of infections. Suppose you have a chicken pox, then you will have permanent immunity for the whole of your life. If you suffer from measles, you will have permanent immunity for the whole of your life. This is active natural immunity. Whatever you get from mother is called as passive natural immunity. Then you have an adaptive immunity which is artificial also. Now artificial immunity can be imbibed by either passive method, by giving immunoglobulins, or by active immunization. So whatever immunization which we do is called as adaptive artificial immunity. Then what is the difference between your innate immunity and adaptive immunity? So innate immunity is something which you are born with, and adaptive immunity you are going to acquire it after your birth, either passively or artificially. So the innate immunity doesn't recognize the antigen which is coming to you. So they are immediate responsive. So whatever antigen, foreign antigen is coming to the body recognizes as foreign antigen and immediately responds because of the innate immunity, but it is not antigen specific. So it doesn't recognize which antigen is typhoid antigen, which antigen is measles antigen, which antigen is a rubella antigen. So it is innate immunity is a non-specific immunity, but it reacts immediately and it's an immediate scavenger for protection. It doesn't have memory also. So you don't have memory cells which are activated because of innate immunity. So the disease which has occurred today will not be really remembered in the another attack with the same disease. But while in adaptive immunity, basically there is a lag period because the antigen enters in the body. The body immune system recognizes this antigen, produces protection antibodies over a period of time. So after the entry of antigen, there is a lag period. After lag period, there is a recognition of antigen. After recognizing antigen, there are antibodies which are formed against this antigen and the protection is achieved. So the adaptive immunity would have some lag period. But adaptive immunity in this, the T cells and B cells are involved, and most of the adaptive immunities are specific to the specific antigen. Suppose you have developed antibodies against measles, then you will be protected against measles. If you have developed antibodies against some other illness, you will be protected against that illness. So the adaptive immunity is specific. Adaptive immunity is generally through the B cells and T cells, and which are refined cells which recognizes the specific antigens once they come in across your human body. Now this is a complex slide which really gives you the insight of what exactly the immunology is. What is the importance of knowing this slide? The importance is basically there are n number of vaccines which we are giving. With few vaccines are given only single dose, few vaccines are given 2 doses, few vaccines require multiple doses, and all the time something comes in your mind that why this is happening, why number of doses are necessary, why few vaccines are given at birth, why few vaccines are given later on. So all these questions can be answered unless we learn this complex slide in detail. Now as I said that we have 2 arms of immunity, one is innate immunity and second is adaptive immunity. We have mechanical barriers which are as a part of innate immunity, and this part of immunity is the first is the skin as a barrier, mucous membrane is another barrier, then you have a normal gut flora or normal mucosal flora which is there in the body. Now this normal mucosal flora, which is called as happy bacteria or happy bacterial cells which are residing in our body, and they would prevent these microcolonization of other pathological bacteria. Then you have surface immunoglobulins which is called as IgA, which is there at the surfaces, which also attracts these antigens and kills these antigens. You have cilia which are mechanical barrier. Then you have mucous membranes where you have different pHs like acidic pH, alkaline pH. All these prevent the entry of these microorganisms. Now let us consider that our body is like a fort or like a city which has to be prevented from the entry of these foreign substances going to the body and causing nuisance in our body. So these bacteria and viruses, they are at the skin surface, they are everywhere, and they are just waiting for proper environment to enter into the body. The moment these barriers like physical barriers or mechanical barriers are broken, these bacteria and viruses, they travel just inside the wall of the skin and they come in contact with the few proteins which are just behind your skin, and these proteins are specialized proteins which tag these antigens the moment they come in contact with them. Now this antigen tagging is called as is from the complements, that is C3 and C5 complements which are produced by the liver, which are just beneath the skin. These complements, they have one arm which is called as opsonization as well as some arm which is going to tag. So by opsonization means these bacteria and viruses are made miscible, transmissible or signal friendly by these C3 and C5. Then you have something which is called as lactoferrin as a protein just beneath the skin. Now this lactoferrin is an enzyme which eats the iron which is required for the growth of a bacteria. So lactoferrin acts on these iron stores of these bacteria and viruses and kills these bacteria and viruses because they don't get iron. once these bacteria and viruses they enter the skin barrier and come inside the body, the complements C3 and C5 they are active, and this C3 and C5 has two arms. One arm is basically anaphylaxotoxin and second is opsonin. So they tag the bacteria and viruses so that they are recognizable by your immune system. You have a lactoferrin like protein which is there in the just beneath the skin, and this lactoferrin is supposed to eat the iron which is required for the growth of bacteria and viruses. So because the lactoferrin eats this iron, the bacteria and viruses cannot grow. Then you have opsonin which makes these bacteria and viruses palatable as well as tagged and recognizable by the immune system. So these are just behind your skin barrier. All these proteins are there and they are produced by the liver. Now what is most important in the immune part of it is, though we have two specific arms like innate immunity and adaptive immunity, they are not two separate boxes. They are working together in the body. So you have one as an innate which is you are born with, and second is basically adaptive which you acquired over a period of time. So all these two boxes they are working together with each other in the body. You have two powerhouses to produce these immune cells. One is called as bone marrow and second is called as thymus. Now this bone marrow academy as well as thymus academy, here the immune cells are not only produced but they are trained, they are matured, and they are taught to recognize the antigen, foreign antigen, and tackle the antigens. Now when you come across this bacteria and virus which has already entered in the body, then you have different cells and different enzymes which are making this complex immune system to work against these organisms. The first and foremost thing which comes in this innate immunity is the cells which are produced by the bone marrow. As all of us know that we have hemopoietic cells which are produced by the bone marrow. There are non-hemopoietic cells like polymorphs, then we have basophils, we have eosinophils, they are also produced by the bone marrow. And these cells, once they are produced by the bone marrow, they enter into the circulation and they go to the site where the action is necessary. Now all of us know that this polymorphs is an effector cell which engulfs the antigen. It has a small burner. With this burner, the antigen is killed, it is burned, and the cell may die in the form of pus cells. So initial response to the antigen is always polymorphocytic, and that is the reason why we get increased number of polymorphs whenever you get an acute infections. This is the effector cell. Similarly, there is another cell which is called as basophils. Now these basophils, once they travel from the circulation and go to the tissue, then we call it as a mast cell. So the basophil mast cells are nothing but the basophils which have traveled from the circulation and which has entered into the tissue. Now what is this basophils role is? Now these basophils, they have granules which is called as histamine granules, and these histamine granules they get activated with some antigenic stimulus and cause whatever symptomatology of anaphylaxis, urticaria, hives or allergy. So whatever allergy we see is only because of stimulation of basophils or mast cells which is causing release of histamine, and the symptoms of anaphylaxis like you get increased secretions, you get stridor, you get respiratory system involvement, you get cardiovascular system involvement, you get a skin involvement. So on the skin you will find urticarias and hives. In the respiratory system you will have increased secretion, increased bronchospasm and stridor. In cardiovascular system you will have tachycardia and shock state. So all these symptoms are related to the release of histamine whenever these basophils come in action. Then you have third cell which is called as eosinophil. Now this eosinophil, the exact role of eosinophil in the management of in immunology is not really known, but it is said that these eosinophils are necessary for the elimination of parasites which come into the body. So the eosinophils, as all of us know, that whenever you have an parasite in the body, you will find an increase in the eosinophil count. So these eosinophils, they somehow work to eliminate the parasites from the body. Then coming to the another important cell which is a part of innate system but which is produced by a T cell academy. So as I said that we have two academies in our body, one is called as bone marrow academy and second is called as a T cell academy. T cell academy means the cells which are coming from thymus or from any reticular endothelial system. So this natural killer cell is a cell which is a part of innate system but is produced from thymus or a T cell academy. Now this natural killer cell is a freelancer in the innate part of immunity. It is already trained. The natural killer cell knows how to recognize the antigen. Natural killer cell knows the happy cells as well as sick cells. So if you see that there are two arms, one arm is having a weapon and second arm is having a hand. So with this hand, this natural killer cell which is wandering through the lymphatics as well as bloodstream goes to almost every cell and pampers this cell and asks, are you happy, are you happy, are you happy? And the moment it sees a sick cell like this, then it destroys this sick cell by the weapon. So that is the importance of natural killer cell in our body. Then coming to the breach between this innate and adaptive immunity. The breach between the innate immunity and the adaptive immunity is called as antigen presenting cells. Now what are these antigen presenting cells? Now these antigen presenting cells, there are only three types of antigen presenting cells in our body. One is macrophage, then second is dendritic cells, and third is B cells. So these are the only three antigen presenting cells in our body, and these antigen presenting cells forms a breach between the innate immunity and adaptive immunity. Now let us go back to the bacteria and viruses which has entered in the body, which has just come below the skin, which has been tagged by our opsonization and complements, and they are now made recognizable by the immune system. So whatever the enzymes which are released and tagging has already occurred with this antigen, this stimulates these antigen presenting cells by toll-like receptors which are there on antigen presenting cells. So there are almost 12 types of toll-like receptors on the antigen presenting cells, and these toll-like receptors are stimulated by the antigen which has come into contact, and these antigen presenting cells come into the action, and now they are ready to engulf this antigen and cause the further cascade. So what will happen? These bacteria and viruses, the moment they come in, either they will be killed by the complements, they will be killed by the polymorphs, or they will be engulfed by the antigen presenting cells, which are the important breach between the innate and adaptive immunity. Once this antigen has been engulfed by these macrophages, they have a little burner and they break this antigen into multiple pieces. And after breaking this antigen into multiple pieces and burning a part of it, they would show off some part of this antigen on their surface. So all these antigen presenting cells, they would engulf these bacteria and viruses by apoptosis. They would engulf this bacteria and virus. They would kill this bacteria and virus. At the same time, the part of this they would break it in the small pieces, and a small part of that virus or bacteria would be displayed on the surface of these antigen presenting cells in the form of major histocompatibility antigen 2 or major histocompatibility antigen 1. Why this happens? This happens basically because now this antigen presenting cell is an active cell which got a co-stimulation from your innate immunity. From this, it has already engulfed this bacteria and virus. It has processed it, broke down it in the small pieces, and it has presented it on the surface to be recognized by the most competent adaptive immunity of T cells and B cells, which are supposed to be there in the lymph nodes. The moment these antigen presenting cells are charged, they release a chemical which is called as interleukin 12. It releases other interleukins also, but what is most important is interleukin 12 is released by these macrophages and it goes towards the lymph node, and once it goes towards the lymph node, you have a T cell academy sitting there where you have trained T cells inside these lymph nodes. Now these trained T cells, though they are trained, they don't have trigger for the action. So this interleukin 12 which is released by these macrophages will cause a trigger to these naive T cells. Now these naive T cells which is already trained, equipped, but doesn't have signal, the moment it gets signal from this interleukin 12 would become active and would be converted into either a T1 cell or a T2 helper cell. So as all of us know that T cells, we have a T helper cell, we have T killer cell and T suppressor cell. The helper cell is not actively involved in killing, but helper cell is supposed to help antibody response from the B cells. Helper cell is supposed to improve your memory response of the antigen, while the T killer cell, which is a type of T1 cell, is supposed to get involved in actual effector killing. So the T killer cell, which is a part of this T1 cell, the moment this T1 cell gets converted into T killer cell, is a effector killing cell, and that effector killing cell is involved in all intracellular pathogen clearance. What is most important is, as all of us know, that we have immunoglobulins and we have a cell mediated immunity. So you have humoral immunity as well as you have cell mediated immunity. So humoral immunity means you have immunoglobulins which are produced. Those immunoglobulins are specific to the antigens. They go bind the antigen and kill the antigen. But you don't have anything to combat the intracellular pathogen. Now what this T killer cell does is basically, cytotoxic T cell does is basically it deals with your intracellular pathogen. So whatever cell mediated immunity which we see is through these T killer cells. Then once this T0 cell is converted either into T1 or it is converted into T2. So you have T1 cell or T2 cell. This T2 cell has two options. One is helper cell, which is going to help, and there is a suppressor cell. So whenever antigen enters into the body, there is a significant antibody response or immune response which is recognizable for few period. After that period, once the antigen is finished, you require something to suppress the immune response. Otherwise, the immune response will become endless. So this helper cell has a fraction which really suppresses this immune response and makes it adequate only for killing. Apart from this CD4 helping this immune mechanism, they now would work on these B cells which are already there in the lymph node, and these B cells are activated so as to form more of immunoglobulins in the body. This is a humoral part of our protection. So B cells, they produce immunoglobulins, IgA, IgM, IgE, all these immunoglobulins are produced by the B cells after the stimulation from the T cells. So if you have any vaccine which works through this T cell mechanism, probably the immune response which we are going to get is going to be robust. Similarly, the B cells are stimulated to have converted into some memory cells. So there are few memory cells which are prepared because of the stimulation from this T cell, and these memory cells recognize the antigen even if it comes across body any time after in the whole of your life. So the function of T cell is, one is basically intracellular pathogen clearance by your T1 cell, and second function is basically helping these B cells to produce immunoglobulins and helping these cells to produce memory cells. So if you know all this, probably here we have answers for why we give some injections which are subcutaneously, why we give some injections intradermally, why we give some injections intramuscularly. The reasons are simple. Most of the live vaccines which we give can be given intradermally as subcutaneously because you have lot of dendritic cells which are antigen presenting cells which are in the skin and subcutaneous tissue. Killed vaccines, whenever we want to give killed vaccines, we require adjuvant to produce an inflammatory response. We require a depot preparation. And when we want to have a depot preparation, then we are supposed to give it to be intramuscularly. So this is the reason why few vaccines are given subcutaneously, few vaccines are given intradermally, while few vaccines are given intramuscularly. Even if you understand this basic immunology, then you will find that whatever fallacies or whatever complications which occur because of this can explain many of illnesses. Like if you have acute inflammatory response, you will get increased polymorphs. If you have anything to do with macrophage activation syndromes, probably you will get all those illnesses which are not really very common but collagen vascular diseases. You have autoimmune dysfunctions, all this can be prevented because if you have immunosuppressions, if you have only pan-hypogammaglobulinemia, you will be susceptible for the bacterial infections. If you have something to do with T cells, probably you will have HLH, you will have something to do with the intracellular pathogen clearance problems. So all these illnesses as a clinical spectrum can be learned only by this slide. Now coming to the what type of immune response we really get. Now when we get an immune response, the antigen is supposed to stimulate either a humoral response or a cellular response. Humoral response means basically you have antibody production through the B cells, and cellular response means you have intracellular protection by the T cells. So whenever you have a T dependent response, the response is supposed to be robust and it is supposed to be long lived. But when you have T independent response, it is going to be only humoral and antibodies would wean off over a period of time. So the vaccine which are T dependent are supposed to be better vaccines than T independent vaccines. Humoral response, there is a lag period, and then you have IgM antibody which is formed, and these IgM antibodies as the period advances after 3 to 6 months, then it is converted into IgG as a late response. But you have lag period, then you have antibodies which are produced by the body, and there is a plateau and there is a quick decline. Secondary response, suppose the antigen has come twice in the body and which has secondarily stimulated your immune system, then this secondary system will have, as already they have recognized this antigen previously, you will have an abrupt, good, early, robust response. So this is called as a secondary response. This is how your second dose of vaccine works whenever you give a vaccine. So primary vaccine dose always gives you antigen stimulation. You will have some lag period, you will have some antibody production over a period of time, and it would wean off over a period of time. But whenever you give a second dose of antigen to these children, this antibody response is converted into a secondary response which is much better than the primary vaccination response. This graph will show you what exactly is happening. This is a primary response and this is a secondary response. Here the lag period is less. Once you give a second dose, the lag period is less, plateau is better, antibody titers are better, and they stay long as far as for the protection. So the initial response is always IgM, which is converted into IgG with your secondary response. Now how do you classify these vaccines? Now for all practical purposes, these vaccines are classified as live attenuated vaccine or inactivated vaccine. Live attenuated vaccines means the vaccine virus or a bacteria is live. It has lost its virulence, it has lost its potency to cause a disease, but it has preserved its antigenicity to stimulate your system to give you protection. So what it is causing? Basically it has lost pathogenicity, but it has preserved its antigenicity. So the antigen which is required to stimulate your immune system to cause protection is already preserved by these vaccines, and that is what is called as live attenuated vaccines. When you have inactivated vaccines, these vaccines are again bacterial, viral, but they are again inactivated with either a phenol red or some other chemical substance, but they still have, though they are killed, they still have some antigenic potential to stimulate your immune system. Now this inactivated vaccine can be whole cell, so you can use a whole cell, you can use a fractional cell. Now coming to this fractional cell, there are few illnesses which are not really caused by the organism as a whole. Like if you see a tetanus disease, if you see a diphtheria disease, these diseases are caused by toxoids which are released by these organisms, and these toxins which are released are to be neutralized by the toxoid. So you use only fractions, that is only toxoid, to combat this antigen to protect yourself from the disease. Then there are subunit vaccines. So you may not have a whole bacteria or virus to be taken. Like you have hepatitis B vaccine, you have typhoid vaccine, where only a small part of a body is antigenic and immunoprotective. So in hepatitis B we use hepatitis B surface antigen, in typhoid we use typhoid VI antigen. So these antigens are sufficient for vaccination purposes to cause a protection. Then there is a second group of vaccines which are called as polysaccharides. So let me tell you that basically all protein antigens are easily recognizable below 2 years of life. So all antigens which are protein in nature can be recognized by our immune system less than 2 years. But those organisms which has polysaccharide capsule, like we have pneumococcal, we have meningococcal, these organisms, they have polysaccharide capsule, and this polysaccharide antigen cannot be recognized by the body till the age of 2 years. So when the illness burden is very high below 2 years, so if you see pneumococcal incidence is very high below 2 years, meningococcal incidence is high below 2 years. So all these capsulated polysaccharide organisms, they have immense mortality and morbidity below 2 years, but still our body is not recognizing when we are giving them as a polysaccharide plain vaccine. So what is the use of giving these vaccines? So what has been done is basically this vaccine or polysaccharide chain has been conjugated to some protein, and this is what is called as conjugate vaccine. So you have a polysaccharide organism, you tag it with some protein which is recognizable below 2 years and give it as a conjugate vaccine. So that is what is simple as a conjugate vaccine which we are getting. So all pneumococcal vaccine, H influenza vaccine, meningococcal vaccine, all these vaccines are conjugate polysaccharide vaccines. So this is a remarkable improvement so these vaccines can be given below 2 years and they can protect these illnesses remarkably. Now, as all of us know that the conjugate vaccines, they really work through the T cell pathway and protect yourself for a long time. Then still why we are giving polysaccharide conjugate vaccines in three consecutive months, again a booster after 1 year? The basic reason behind it is basically what we require is a good GMT titers to protect against these illnesses. This pneumococcal, H influenza, meningococcal, they have a very short incubation period. As they have a very short incubation period, you really require a lot of antibody titers to prevent yourself from the disease. And that is the reason, in spite of the fact that we have a better conjugate vaccine, we need to give multiple doses of these conjugate vaccines to these children. Then dendritic cell role, as all of us know that basically now I have talked to you that there are only 3 antigen presenting cells in the body. One is called as a macrophage, second is called as dendritic cell, and third is B cell. So only 3 antigen presenting cells are there. But the dendritic cells are abundant and they are not only in the lymph node. The dendritic cells are there in the skin as well as subcutaneous tissue, and they have an immense role to play at both the places. In the skin and subcutaneous tissue, they are basically the first antigen presenting cells which are there, and in lymph node, basically they are involved in maturation of these immunoglobulins which are produced by the B cells. So in germinal center, this dendritic cell role is different, and in periphery, the role is different. Then how vaccine works? Now whenever there is an infection or whenever the antigen is already given to the patient, the B lymphocytes, they are activated. These B lymphocytes, they become plasma cell, and from these plasma cells you have production of antibodies which may be IgM, IgG, IgA, IgE or IgD, depending upon the stimulus which the antigen is going to give. Now this extrafollicular reaction is something which is occurring outside the follicles or outside the lymph node, and something which is called as intrafollicular reaction, which is something which is occurring during the or inside the lymph node. So whenever you have lymphoreticular system like spleen, lymph node, you have pre-committed B cells in the body. Now these pre-committed B cells, whenever there is an antigen stimulation, they are converted to the plasma cells, and these plasma cells, they convert themselves to produce immunoglobulins in the body and cause protection. In follicular reaction, there are three things which are occurring in follicle or lymph node. One is basically the maturation of immunoglobulins which are coming to the lymph node. From IgM to IgG class switch over occurs in follicles of the lymph node, as well as memory cells from B cells are produced in these follicles. So these 2-3 things which are occurring in follicular reactions, they have impact in protection and long-term protection because of the memory B cells which are produced in the follicles. Now, the live vaccine, what is the difference between live vaccine and a killed vaccine? The live vaccine itself is basically it mimics like a natural infection. So whenever a live antigen enters in the body, it would have some lag period and would cause a disease or cause a protection. So there is some lag period. Then this live vaccine would not only remain locally to the lymph node, but it would have multifocal clonal expansion at multiple places in the lymphatic system. So it would expand into the lymph node, it would go to the spleen, it would go to the multiple lymph nodes. So you will have multiple foci of producing protective antibodies to you. So the live vaccine spreads to the body. It goes easily to the all lymphatic organs and it has a multifocal expansion, and that's why the live vaccines are better to give protection than the killed vaccines. The only problem with the live vaccine is that they cannot be given in immunocompromised children and they are still contraindicated in pregnancy. Now about the killed vaccines, so whenever we come across an immune-compromised child or whenever we want to give some vaccine to the pregnant lady, we usually prefer a killed vaccine. So the killed vaccines are also effective, but they require some adjuvant to cause a good immune response. Here the killed vaccine antigen remains locally. It spreads only to the local regional lymph node and cause a protective effect. So you have a limited role of production of antibodies when you use killed vaccine, and so whenever you are using killed vaccine, you require number of doses to be increased so as to achieve the protection of the patient from the disease. Now, why booster doses are necessary? As I explained, that we have a primary response, we have a secondary response. So in primary response, the antibodies are supposed to hype at a lower pace, they stay at a plateau at a lower place, and they immediately wean over a period of time. But if you give a second dose, then it is an accelerated response, and the IgM antibody response is converted into IgG response, which is quite long. Then what is the T cell independent vaccines? So T cell independent vaccines, most of the killed vaccines, they are T independent vaccines and they do not have memory cells which is activated, so they have a limited role. While T dependent vaccines, they have robust response and they stay long in body and they have a good response. So multiple doses of T dependent vaccines are not necessary, while T independent vaccines you require multiple doses to be given. There is something which is called as winning antibody levels, and these winning antibody levels is the only reason why we give booster doses in most of the vaccines. A concept of short incubation period and long incubation period. See, basically we know that the conjugate polysaccharide vaccines are good enough. They stimulate your immunity appropriately. They have long-term protection. Still we give number of conjugate vaccine like polysaccharide vaccines like pneumococcal 3 doses, 1 booster, 3 doses of H influenzae, 1 booster. So all these things are given only because the illnesses, they have a very short incubation period. So you really require a lot of antibody titers or GMT titers to protect against these illnesses, and that is the reason we require multiple doses of these vaccines. About long incubation period, now if you consider hepatitis A and hepatitis B, which has a very long incubation period. Suppose if you had received 1 or 2 doses also of this vaccine, there will be memory cells which are being activated, and because of the long incubation period, the body gets time, even naturally infected by this hepatitis A or hepatitis B, to produce his memory cells and protect the person from the disease. So for long incubation period, we really do not require multiple doses. We require hardly 1 or 2 doses to be given in the long incubation illnesses, where we have a role of memory B cells which becomes active and protective to the children. Thank you.